Hello everyone, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. This topic is a highly contentious topic, but a very important topic because of the fact that this is one of the few types of frameworks that is available out there that you can systematically conduct social research. And what I've provided is an EKG machine to show you that in electrophysiology you can do this. You can do this in the field of criminal justice. You can do this in the field of counseling. So this is not limited to one discipline or another. The EKG and the running of the EKG tells you a lot of things about the individual, but then also the community that the individual belongs to. For instance, if somebody is experiencing atrial fibrillation, this might be as a result of multiple complex community factors that have taken place, and that is affecting a whole community. So the problem with social determinants of health is not that it's too short. That there's not that much to talk about. The problem always is that you run out of time talking about each of the 5 domains of the social determinants of health. Take economic stability. You can take that and talk about the different components of economic stability for hours on its own. Food insecurity is in and of itself a very important social contributory factor in terms of health outcomes. Introducing this conceptual framework for social determinants of health, this is very important. I've not only done this here, but in additional videos. And I usually like to say that there's 4 varieties of social determinants of health. 2010, the Commission on Social Determinants of Health met in the World Health Organization, but then since then, the Kaiser Foundation and some of the other organizations have come together, and also the Centers for Disease Control and the United States have created their own perspective on social determinants of health. There's 5 domains, of course, built environment, healthcare access, food access, all of these things matter. Social cohesion and social connectedness. These things are all parts of understanding these types of social determinants of health. So just going back to kind of the starting point of where some of these models took its place, the social health factors have been explored by researchers using several models, but the most widely used is the Dahlgren-Whitehead rainbow model. So this model was developed by Goran Dahlgren and Margaret Whitehead in 1991. And the maps, and this actually maps the relationship between the individual, their environment, and health. And of course, what is really important and fascinating about this is that the individual is placed at the center of this, and surrounding this are all of the various layers of health. So in the center is the individual characteristics. And then surrounding is a lot of the lifestyle factors, community influences, living and working conditions, and general social factors. This is arranged in a specific way. So at the center is individual factors, age, sex, and constitutional factors, and that is in red. And then in the surrounding is social and community networks. And what I want you to pay attention to here, which is not necessarily in the US model, is the agriculture and food production. This is very important. I've lectured on this individually. And then water and sanitation. This is in the Sustainable Development Goal portion of the World Health Organization, but not really emphasized in the U.S. model. And that may be because this is not as much of a focus, but still should be a focus. So transitioning over to understanding some of the disparities that exist within the United States. So when we're talking about disparities, it's important to keep in mind that we're not just focusing on disparities based on one characteristic or another. Rather, we're actually looking at race as one of many types of characteristics of classification. So, for instance, gender equity is also a very important issue. Additionally, you have sexual orientation and other types of sorts of disparities which cause, through intersectionality, additional disparities. So this is disease disparities by race, and this is including data on 2018 infant mortality, and this is going into JAMA and looking at multiple conditions. This is looking also at homicides. And how this is affecting disproportionately blacks more than whites, but also a human immunodeficiency virus, HIV, nephritis, cancer of the prostate, diabetes, mellitus, even septicemia. So this is an acute condition that you get during your hospital stay. But cancer of the breast, cerebrovascular disease, colon cancer, and diseases of the heart. So these are all of the areas that need much more concrete research, and the data is already there. The data is available. It's only a matter of putting it all together and providing more robust sort of comparisons. This can be done in a geospatial fashion. This can be done in further exploring and further extrapolating existing nationally representative data sets. On the right, there's a distribution of course, infant mortality distribution, and as you can see, strikingly, out of all of them, the highest is among the black population, the non-Hispanic black, and then after that is Native American, and then Hispanic, and then non-Hispanic white. So infant mortality rates are still extremely high among historically marginalized populations. This is the message here. So I told you at the outset that I typically consider social determinants of health when I think about this. And people have different approaches of understanding this, but I think of it as World Health Organization and the Commission on Social Determinants of Health as the origin framework in 2010. Although I do agree work was being done by sociologists in many of the Ivy League institutions, a lot of a lot of this important work did not come together until a powerful sort of conglomeratory organization like the World Health Organization put it all together. Then the county health rankings model, of course, was there. The Centers for Disease Control had been putting the model together as well from the domains that were put in place. So then, of course, the Kaiser Family Foundation county healthy rankings, but also Healthy People 2030 was there as well. So we're going to jump right into the Healthy People 2030 5 domains: education, access and quality, healthcare, access and quality, neighborhood and built environment, social and community context, and economic stability. These are the 5 domains, but they're very detailed. There's 355 objectives that actually inform these domains. There's improvements to be met. There have been baseline measurements that have been made. So this is a really, really good resource if you're thinking about using social determinants of health in your research work, or building within your community, planning for specific intervention. So I transition on over to talking about understanding why we need to be conducting surveillance in terms of some of these social determinants of health domains and indicators that I have just informed you about. Well, recent evidence suggests that the increases in life expectancy during the past 20 years have come from improvements in disease management rather than prevention. So what I'm trying to say here is this. I mean, look, we need management, of course, but we need prevention as well. We just need a combination of both. And county level variations in life expectancy, these need to be measured first. For starters, we need to make sure when we're looking at these, and geospatial maps are the way that we can do this, and show the need to address structural disparities related to chronic diseases. People are living longer and longer lives, and there's disparities in this. And so if we want to address any of these structural disparities, it will have to come in the form of not only overall measures, but measures as it pertains to chronic diseases. Cardiovascular disease, this needs to be addressed. Diabetes, this needs to be addressed. Obesity, these needs to be addressed. So all of these things are there and needs to be monitored. So if we need to address something, it needs to be monitored to look at concrete trends and actual empirical numbers. What do we have currently? I mean, what we have currently, is that sufficient? No, the answer is no, it's insufficient for tracking progress in efforts to monitor trends in quality of life in the United States overall or within communities. We really need to do more to track a lot of this progress. And that means that we have to have more mobile examination centers and units, similar to what National Health and Nutrition Examination Survey does. We have to go into the communities and actually collect a lot of these data, a lot of this data. This is done in a lot of smaller health systems where this is sustainable. For instance, in island populations, also some of these clinics can be sustainable, but we have to find more unique ways that we can then serve specialized systems, and then also provide this. And so more people now more than ever, the bottom line is this, are living with chronic illnesses. And this is as a result of the prevalence of illnesses. Maybe it's being defined better, but people are living longer too. And so longer survival means among patients, there's more chronic disease. But also I want to emphasize that the equity gap, the income equity gap increases, has increased and keeps increasing. And once this equity gap, if this is not addressed, these economic disparities will just keep persisting. So you've gotten to this point now. Um, you know that there are disparities within society. I've convinced you, hopefully, that these social disparities exist. What do you do? What can you do? You're armed with information, and you're armed with some tools which you can actually use to synthesize some of this information into knowledge that then society can take, become aware, and make informed decisions about their lifestyles and about their behavior. And then societally, we can actually address some of these disparities that exist to begin with, to make more of an improved society. So here are four very important data sets which I have done extensive research on. I've helped students mentor into finalized research projects, but I myself have completed original research projects from these. The first one I've mentioned multiple times already in this lecture, and that is the National Health and Nutrition Examination Survey. But also the Behavioral Risk Factor Surveillance System, the Surveillance Epidemiology and End Results Program. This is a really good data set for cancer, which I would highly recommend. A lot of good survival analyses have been conducted, I've been a part of. And then also the National Health Interview Survey have actually helped students go through projects through these from start to finish. And guess what? All the data above is free. And so free is always good. All right, so if we were to take some of these social determinants of health and then present to you some of the targets, I told you there's objectives, about 355 objectives that have been identified along with the social determinants of health. But what if I told you there's some targets that are being kind of addressed as well? Give you a slightly different perspective. And give you some examples. I think examples help to illustrate nebulous frameworks sometimes. I oftentimes find them useful. So when we're thinking about genetics and epigenetics, there's quite a few things that come to mind. Of course, the BRCA1 gene, that is something that nowadays, if there is even a presence of this, some individuals choose to go through mastectomy due to the potential breast cancer from this. Screening from Huntington's disease. This is very important. The CAG repeat is actually a set of nucleotides which repeat, and they actually become earlier with each progressing generation. So it's a movement disorder. It's a tragic disorder, and really requires close screening. Down syndrome is something that is preventatively screened, within the quad screen among newborns, in the fetus. And then, of course, there's attributable risk of familial diseases. Tay-Sachs disease is one example. Then we move on to behavioral risk factors and self-management. And these are some that comprise a significant amount of social determinants. And of course, that includes smoking, dietary fat intake, exercise, and alcohol intake. And so, the traditional thinking has been this, I would say for the last half century, is the onus is on the individual. We have to address these lifestyle issues by the individual, or else then there's not enough. And this is how I was trained as well, in fact, in my public health curriculum. But I want you to shift your thinking a little bit. I don't want you to be going into society thinking in these terms. The idea is this: the neighborhood deprivations, the societal conditions that were around made it such that smoking was much more of a norm in these societies than in societies where some of this knowledge might have actually existed. So there's evidence, there's repeated evidence, not only with smoking, but with a lot of environmental toxins, that corporations did not make it an effort to try to inform the public. And so a lot of times this information was not made available equally in all neighborhoods. And now this has been connected to economic achievement and economic status and everything. Similar things can be said about dietary fat intake in terms of how when you have the lack of availability, carbohydrates are the only nutrition to rely on more so than other types of food. So education of the fact that more nutritious foods can then also be purchased at certain monetary levels can help to improve that. These are all I'm providing you with social determinants of health scenarios, and then I'm also providing you with certain intervention, community level interventions that can help improve these areas. And the thinking has changed completely in not only medicine but public health, where behavioral risk factors now are more closely connected and intertwined with socioeconomic and environmental factors rather than looked at them independently. And many of my colleagues continue to, in public health and other disciplines, continue to look at this individually. And put a lot of emphasis on this, like even medication adherence, glucose monitoring, too much emphasis on the individual, and the onus becomes too much on the individual, and not understanding that societal factors are the reason to begin with that some of these behavioral risk factors developed. So now that I've made that point from that soapbox, let's look at the environmental and the socioeconomic factors. The environmental factors, of course, what zip code you live in is actually more important than genetic code, and this is a statement I've been making continuously, repeatedly in many places. But occupational, household exposure, of course, of certain chemicals. But also recently, this is more of an issue with mass shootings, is neighborhood violence and the availability of gun sales, and how this is within the environment made it much more of a place of stress and anxiety. Our neighborhoods are no longer safe. We always used to send our kids to schools thinking that they would be safe. We would be going to churches to worship, or synagogues, thinking that we would be safe. We would be going to supermarkets thinking that we would be safe. Well, all three of these places in the last 2 or 3 years have seen mass shootings. This has got to stop. Policy has to inform this. So the final portion of this is socioeconomic status. Food insecurity continues to be an issue. Housing insecurity, income levels, education, health, literacy, even zip code there actually has an important part to play. But not getting access to nutritious food on a regular manner is something that is detrimental. And food is such a thing that is cyclical. So if you eat nutritious food, then that becomes kind of part of your habitus, part of what you do all the time. And if you're growing your own garden, your own vegetables and plants and things, and kind of reinforcing what you already naturally normally eat with some of the natural plants, then that allows for better enrichment of your diet, and then also feeling happy about yourself, and a more just overall fulfilling life. So moving onward now, talking about major types of surveillance systems that are out there. NEDS is a good one. It's a broad initiative that was focused on the use of data and information systems and standards to advance the development of efficient, integrated, and interoperable surveillance systems at the state and local levels, facilitating sharing of appropriate data across jurisdictions. And it's a mouthful. There's a lot of information there, but what I'm trying to say is, you not only need efficient data, but it has to be interoperable. You have to have information systems that communicate across groups and across state and local levels. The next one is National Biosurveillance Integration Center. This integrates, analyzes, and distributes information as well. So take a look at those two. So again, think about when we're thinking about social determinants of health, try to put it into perspective in the whole gamut of where it sits. So try to put it into perspective in the whole continuum. So you have environmental, social, and personal determinants of health, and then you have health outcomes, and then you have certain symptoms to be looking for. So when you're conducting surveillance, those are three things that you may be wanting more information on. This is actually a bit dated. It's 10 years old, but I thought that it was relevant to this talk because we have been talking about living well with chronic illness, but there was actually a call for public health action, and there's a whole committee. I think this should be reconvened, and honestly, what caught my attention, it was actually an effort to reduce disability and improve functioning and quality of life. And when students are oftentimes first starting to put their fingers on what it is exactly that they want to study as an outcome. Like, how will they understand if there's an improvement or if there's if there's an improvement or if there's a deterioration in condition? And the way to do that is to identify a precise variable or variables um, that will show that some empirical variable. So for the first starting point always, for everyone is, everybody comes up with the answer, and you probably think mortality. So mortality is the number one answer for people to think. So if there's an intervention that somebody proposes which decreases mortality, hey, I think everybody will be prescribing to that intervention, or going for that intervention, or if it's an actual drug, and if something's decreasing mortality, we're all interested to talk about it. So it's so much so that each year the MMWR, the Morbidity Mortality Weekly Report, actually releases the 10 top causes of mortality. And of course, every year cardiovascular disease ends up, unfortunately, on the top with, claiming the lives of about 700,000 people a year. But the point is that we're not going to make any headway by just addressing mortality. We have to start looking in some other more detailed sort of measures like quality of life. I did lecture on another composite index, but we have to start looking for composite measures. So when you find composite measures, when you're thinking about social determinants of health, make a list of composite measures. Make a list of some of these things. So disability. This might be another disability adjusted life years, dailies. And this actually was part of this measure was one that I talked about in a chronic disease lecture as well. So be on the lookout. Also, years life lost. YL. So be on the lookout for non-customary sort of mortality, something aside from mortality, morbidity. All right, so kind of let's scale back now to talking about some of the surveillance for chronic illness, and this was again from 2012, but it's 10 years old as of this recording, but very important because it's going into some of these environmental, social, and personal determinants of health. And if you look, I know it's a bit tiny here, but if you look on the very right, what I really enjoyed and appreciated about this is that there's a lot of different surveillance systems which you can easily take advantage of right now. So county health ranking, CPA census, MEPS data is available, NHIS. So just take a look at all of these. And how is the patient reporting taking place? This is good too. So this is all self-reporting. And then some of the factors on the left, physical and health environment. So if we're looking at some additional measures that you might be interested in, there's some additional variables. Activities of daily living, that's another measure that's important. So it's also good at good to look at some of the symptoms that will interfere with living well. And some of these include, for instance, fatigue. So when you're thinking about like chronic disease surveillance, then you should be thinking about some symptoms too, which are common to multiple chronic diseases, not just one. And that's why chronic disease epidemiology is challenging more so than anything else, is because you have these common symptoms. So like for instance, fatigue, this is one. And so if a person, which this is oftentimes true when they come to the clinic, if they have congestive heart failure, if they have depression, if they have chronic obstructive pulmonary disease, arthritis, then more than likely they're experiencing fatigue. So the effects of fatigue can actually be then measured in certain ways. So that's one. Of course, pain is an important one, and understanding cognitive impairment, but also dyspnea and distress. So the types of surveillance that take place are sentinel surveillance, registries, and then survey combining physical exam data and self-reported data. So you can take a look at some of these selected chronic disease data source and surveillance systems. And of course, there's notifiable diseases, which are state-based. For instance, lead poisoning. This is notifiable in reporting systems. And the data are available at the local level, usually coupled with a public health response. For instance, lead paint removal. Detailed information can be collected to aid in designing control programs, and then lab-based systems are inexpensive and effective. So what do you want to do? I mean, this is an example of lead-based surveillance system that has been set up for some sort of chronic disease when you're trying to better create a social determinant of health intervention. If you don't collect the right types of information, then you really don't end up with the proper type of social research for social determinants of health. So the reason I'm going into some of this surveillance detail is to show you some of the different examples. But I don't want you to get lost in, at this point, trying to understand what the different types of surveillance systems are, because that can then be done at a later time. What is health equity? This is an important definition. Pay attention to this. When every person has the opportunity to realize their health potential, the highest level of health possible for that person, without limits imposed by racial and structural inequities. So health equity means achieving the conditions in which all people have the opportunity to attain their highest possible level of health. So this is adopted from the CDC definition. But the idea is this, that health, the highest level of health each person deserves access to. The highest level of health. So So I'm not going to go into a lot of detail. This on this framework. This is actually the 2010 Commission on Social Determinants of Health approach, and I've actually gone into a lot of detail in one of my videos. So I encourage you to look into this into that video. But there's a lot of emphasis placed on socioeconomic and political context and socioeconomic position. So this is the famous tree example, the tripartite model, but providing an example of the root causes that you cannot see ever really. It's these adverse living conditions, the poor quality schools, the segregation, all of these things. They're kind of unemployment. They're creating the conditions then for the trunk to wither away, and then the branches. And so you create a social condition which is fully ridden with violence and substance abuse, smoking, HIV, infant mortality, malnutrition, obesity, depression, heart disease, and stress kind of as an overall theme that wraps all around all of these inequalities, all of these inequities within poor communities. So in order to build these better, in order to rebuild our communities, in order to make sure that our communities are empowered, in order to make sure that people that have not been heard, that deserve a voice, get a voice, we need to get to the root. We need to have systems in place. We need to have adequate income to begin with. Quality schools, schools where students are being treated equally. The investment in resources are equal on each pupil. We need to have health insurance. We need to make sure that Medicaid expansion is actually being implemented everywhere. And we are actually protecting our marginalized populations. So this leads to then social support, social networks, a sense of community, leadership, political influence, organizational networks. If all of these things are addressed, then our communities cultivate, our communities nurture, our communities create good overall health. And that is the foundation of social determinants of health. You won't have if you have a community where there is not low malnutrition, where there's low malnutrition, where there's low obesity, where there's not as much depression, then you have a healthy community. And that is the crux of this model as well. There's differences between health disparities and health inequities. Health disparities are differences in the incidence and prevalence of health conditions and health status between groups based on race, ethnicity, socioeconomic status, sexual orientation, gender, disability status, geographic location, or a combination of these. Now, health inequities, on the other hand, these are systematic and unjust distribution of social, economic, and environmental conditions needed for health. So do you see the difference in what health disparities are and health inequities are? Disparities are the actual manifestation of the differences in the incidence and prevalence of health conditions, whereas the inequities are actually the systematic and unjust distribution of socioeconomic. These are the conditions that make it possible for the health disparities to exist. So the inequities lead to the disparities. So the unequal access to quality education, healthcare, housing, transportation, other resources like grocery stores, car seats, unequal unemployment opportunities and pay income, discrimination based upon social status, and other factors. So now let's go through and compare all of these. So I already told you about disparities. Disparities are think about them as the outcomes. What is the effect? Think about the inequities as the conditions that cause this. Now, what is health equity to begin with? That is the opportunity for everyone to attain his or her full health potential. So if that opportunity does not exist, that opportunity is then leading to a health inequity. So do you see how this builds one on top of another in a more scaffolded manner? So no one is disadvantaged from achieving this potential because of his or her social position or other socially determined circumstance. So it has to be equal access to quality education, healthcare, housing, transportation, resources, equitable pay, income, equal opportunity for employment, and absence of discrimination based upon social status or other factors. So now that we have clarified some of these definitions, now it's time to be thinking about the social determinants of health. And that is the life-enhancing resources whose distribution across populations effectively determine length and quality of life. And of course, this is one of many definitions. One is these are the conditions that help the person to live, that they're born into, live, work, and play in. And so this is what is the crux of social research. So when you're, again, I emphasize on chronic diseases a lot more in trying to articulate the social determinants of health, because the place where you will be really seeing this most manifested and most demonstrated is in the realm of chronic diseases, where with an aging population and also with increased health disparities, chronic diseases are what are the basically the top 10 causes of mortality, and that includes mental health. Thus the increased emphasis on this. So if we're to look at social determinants of health a little bit more broadly now and expand our horizon and make sure that we're actually including everything that there is to include, I think it's important to note that, of course, there's access to healthcare, access to resources, education, employment, environment, these things that are so important. But income, poverty, insurance coverage, housing, racism, discrimination, segregation, transportation, these are all extremely important as well. So I created this BFF model. Before you get started on any sort of social determinants of health research or any sort of exploration within your community of understanding what are the gaps and needs, you have to understand what are those gaps and needs. And so I created an acronym, a BFF acronym, where you browse the objectives to learn about the national goals to improve health. Maybe your country doesn't have one. But more than likely, if you look in the United Nations Sustainable Development Goals, somewhere there's some sort of objectives or some sort of indicators that have already been provided within your country, which then you can take a look at and then compare with other countries and whatnot to try to indicate the most optimal types of interventions. So first, once you browse those objectives, then you align with the priorities that you may have. And so you don't want to, of course, make the priorities too ambitious. If they're too ambitious, then you have too many things that you're trying to accomplish at the same time, but then at the same time, you don't want to make them so extreme that it's not something that will be achievable. A lot of the sustainable development goals, in fact, when they were put in place back around in 2014 or so, there was a lot of hype and excitement around that. But then when the 2.5 year, well, even more now, this pandemic happened, the COVID-19, that derailed a lot of these plans. So it's important to have realistic, specific, measurable, attributable, realistic and timely goals. And then focus on groups affected by the health disparity, specifically the historically marginalized populations are especially important to be looking at. So what goes into considering your health? And this is controversial by definitely depending on who you ask. So if you're asking a purist in terms of somebody who may only go by historical information, these percentages might be that they're saying or thinking that health behaviors may be taking on more of a role, or maybe some people might say that socioeconomic factors and this will actually take on the vast majority. So a social researcher will give a higher percentage to this. But I think realistically speaking, if we're to be taking a look at this within the clinic, you'll find that 40% is about socioeconomic factors, and of course, where your clinic is located, that value might be a lot more. Trust me. So these are not my message with this. My teaching point in this slide is that these percentages vary, but just keep in mind that these four factors are what comprise a person's health. So physical, environment, health behaviors, and healthcare. So where racial and ethnic minority groups are highly represented by county is something that is important to note. And in some places there's so this is all different populations, African American population groups, or Hispanic population groups, and so different groups. So bottom line is we're not one color. There's intersectionality between colors, and if you think about some of the models, they exist, and of course place definitely matters. So if we're thinking about geospatial locations in social determinants of health, that matters. Another area that really matters and is important is racism and how it affects overall health. And as I'm going through this model, what I want you to focus on here is, of course, this is talking about racism, but any sort of discrimination that you may have faced in terms of within your lifetime, in terms of even disabilities, ableism. Um, Maybe many, or I would say some, face dyslexia. Others face uh, conditions, health conditions, which they struggle with constantly. Um, and coming from somebody that has experienced chronic conditions on a for a long time, and overcome in some ways by awareness. I think it's very important to not feel like you're any different than others, but also when you're facing some of this discrimination, whether it's racial discrimination, to be aware of this psychological stress that you're going through. This discrimination, the stress that you experience, um, that can actually be in terms of denial of certain goods or resources, and we of course witness this in many minority populations, but also in terms of understanding when HIV was first coming out, and this was considered only in the LGBTQ plus community, and so especially homosexual men were the ones that were targeted, in fact, by communities. So there's not only denial of goods, but there's actually an assault that people experience. So this then leads to, I mean, this is only human nature. Negative coping behaviors, physiological stress response, and the person starts to develop psychological symptoms. This is the impact, and so the mental health outcomes, and we cannot de-emphasize or forget about mental health when we're talking about social determinants of health. So the mental health outcomes are anxiety, depression, and substance use and misuse. But then, one can say mental health, this doesn't have any impact on physical consequences. I'm going to tell you, yes, it does. And here's how it is. Physical health outcomes: cardiovascular disease, decreased birth weights, increased blood pressure, and physical injury. These are all potential consequences of discrimination. And I'm intentionally not mentioning racial consistently, because this is, in fact, was identified as initially in racial discrimination, but some of these can be experienced in other ways as well. So, I mean, you can see poor living conditions, decreased quality of life, or access to healthcare, but this is where these disparities between the haves and the have-nots exist. And I think if we don't get a grip on this and address these disparities soon, income inequities, racial segregation, disparities, some of the income inequities, and also technological gaps. If we don't address these soon, then the health problems that we continue to talk about, and even some of the medical problems, you'll continue to see these in the clinic. you'll continue to see these in the hospital, and they're not going to get any better. So we have to make an active effort in society. We have to make a call to action. I'm always for advocacy and translating research findings, knowledge to action. And the fact that I've gone over this diagram with you, and I've provided you with the reference below, so you can actually read a lot more about this. But the fact that I've gone over this information and knowledge with you now, it's your responsibility to go out there into social media, to go out there to your circles, and then impart this knowledge in ways that you can. And so I make succinct messages. I have examples of these messages that I then also provide. And a lot of these are calls to action, advocacy pieces, I would call them, more than anything. So this is a fairly this is a fairly small kind of writing, so you're gonna have to bear with me here as I'm try to zoom in here. And we can actually skip that one and move on to this one, and it will be in your slide deck included, but this one actually goes into a little bit more about kind of looking at structural factors and individual factors and the connection that's there. It's a busy slide, but just to give you another idea of the fact that there's a lot of different aspects going on. Even hostility has been included in here, genetic factors, endocrine metabolic factors, privilege versus oppression. So there's a lot of things going on in this slide, and you can kind of take a look on your own. But I think the biggest thing that really you really can take a look at is over time how privilege may act as a determinant of health. So maybe initially some of these cultural, ideological worldview, institutional factors, they weren't causing any sort of effect on the individual level. But as you move forward, this starts to become worse on the individual. So you're first it's just the worldview, but then you experience that systematic privilege and oppression, and then now you're here, interpersonal realm, where you're experiencing this a lot more as a social identity and location, and along the life course. And I think that is what is important to emphasize here, that along the life course, all of these are combining now with psychosocial factors, genetic factors, biopsychosocial factors, biophysical processes, but biopsychosocial processes, health status, interpersonal, internalized oppression, and then how that affects behavioral factors. So that's a better way to provide you with some of these different facets that are playing a role. And the biggest contributor of this model, why I wanted to present this, is that it goes through time and shows you specifically what oppression and privilege does, and some of the other models don't do this. Here's another 2020 model, including racism and health, but the reason I included this one specifically is because one is looking at race-based medicine, whereas one is looking at race-conscious medicine. And I think this is a distinction that should be made in many disciplines, but as you're practicing medicine, I think good to be keeping in mind what is conscious versus based medicine. So when you're thinking about race-conscious medicine, this is more a social and power construct. So you're actually treating the subject of race being defined as a social and power construct. Whereas sometimes when it's race-based, you're just kind of, and many times, many organizations, institutions are guilty of this, where it's ill-defined and kind of just inferred to have this biological significance. This approach is definitely important because we're trying to use from an epidemiological context and other perspectives, confounding and trying to understand subgroup analysis. So let me go through this and show you how this is done. So epidemiological and clinical studies link race with disease. Basic or translational science studies link race with biology. So when in medicine, we're actually looking in both, but we're having to, in basic sciences, look at race, right? So this is the basic sciences right here, down here. And then we're looking at it from a research angle. And then when we're thinking about medical education, we're looking at it from a biologized concept of race being reinforced, and then racial groups understood as inherently potentially diseased. And the challenge here is when you're collecting data on national levels and global scales, being able to make the distinctions between people that are within one race versus people between races. So what do I mean by this? So the concept is this: the similarities among people within one race sometimes are actually less than the similarities between one race and another race. So when we're trying to classify by race, we run into some of these challenges where how do you grapple with some of these similarities and differences, and how this affects the person, the individual. So when something is purely genetic in inheritance, for instance, sickle cell disease is purely genetic in inheritance, then how do you define race then? Because there's different ways and definitions and inheritance patterns that actually changes. Now, when we shift over to epigenetics, some of the social factors start to actually combine in with the genetic factors, and so that is one way that is race is involved with epigenetics. And so when we're looking into clinical practice, how does all of this translate? The other important point to make here is that some of the collective experiences of individuals that belong to a certain race a lot of times dictate how that person then behaves in society. And so when the collective experiences have been felt in a similar manner, then that person belongs more to that one racial group than another. So there's exceptions in some of these designations. For instance, typically Hispanic is its own designation in the U.S. Census. But for instance, you could be both Hispanic and Black, and so there's a separate designation for non-Hispanic Black, and yet a Hispanic Black individual may have more in common with Hispanic individuals than a non-Hispanic Black individual. So this is where the race starts to become an area where there's exceptions, and then based on that, there's actually differences in how it's treated among social determinants of health. But the bottom line, the message here is clear that we really need to look at race in a more in-depth manner. So racially tailored clinical practices, healthcare bias and stereotyping, and then racial health inequities. And then, so race defined as social and power construct, effects of structural racism analyzed. So this is race-conscious medicine now. We're talking about race-conscious medicine. And so here we're starting to see this, starting to look at this early, the effects of structural racism. Consequences of racism on health is being actually taught within the curriculum, and so when you're doing research, you might be, you might look at this, and then of course support provided to overcome structural barriers to health, and that results in reduction in racial inequities. So when you're doing race-conscious research, it's important to note the diversity of the people that you're working with, and the fact that they're even though they might be linguistically belonging to one group, or they might be belonging to maybe more of a native group, or another linguistic group. There might be characteristics that might not allow them to be specific members of one or another group. So now that we have gone through the content of a lot of this material, who does your community include and who does it not? That's really important to know. I mean, what do you consider part of your community? What are the geographic boundaries of that community? Because potentially you're wanting to conduct a geospatial analysis, and a lot of your work will involve conditions within the United States. So what are the cultural and psychosocial experiences of people in the community? And more importantly, does your community have multiple communities within it? And how would you describe some of these communities? And so, like for instance, in the community that I reside in, there's Amish community. In fact, there's multiple, for instance, Old Order Amish Mennonite communities, and very few people know about this outside of some of the local areas. So I feel like in our discussion of social determinants of health, it's important to be cognizant of many things. When you're thinking about social determinants of health, what social, economic, environmental conditions affect the whole community? Maybe it's air pollution. A lot of people are maybe getting sick from COPD. Maybe they're getting COPD exacerbations, chronic obstructive pulmonary disease, or asthma exacerbations due to air pollution. Maybe there's a really high concentration of fast food restaurants. Maybe there's inadequate public transportation systems. What conditions differentially affect subgroups in your community? Why are these conditions experienced differently for subgroups within the community? These are all questions that I want you to really think deeply about. And when I say in your community, it may not be the community that you are currently residing in. It may be the community that you were born in. It may be the community that you work in, that you live in, that maybe you visited once and wanted to make people aware of more. So I'm going to end with this. There's a lot of theories, lots of theories that I've provided you, a barrage of theories in social research. I started by telling you that I was going to just talk to you about social determinants of health, but as I was giving you example after example after example, I had to give you some tailored, targeted examples of specific sort of scenarios where social determinants of health are applicable. If you're doing work with food insecurity, if you're doing work with housing insecurity, trying to understand more information about the homeless population, or if you're doing more research, more social research on very difficult, complex chronic kidney, either chronic kidney disease or chronic diseases that affect the kidneys chronically. For instance, rheumatoid arthritis or systemic lupus erythematosus. One or the other, it's affecting the kidneys. So take a systems-based approach there, but take nothing. None of these concepts are in an island. The idea is this: it's all connected. We have to get a good handle and grasp on all of the different facets, and if you learn the ideas little by little, if you take bits and pieces, put them together, then trust me, from a seasoned social researcher, I'm telling you, you will have no problems applying social determinants of health. But don't forget about Healthy People 2030, because that is your primer to being able to apply social determinants of health effectively within society in the United States. So I'm going to leave you with the epigenomics, social epigenomics. And the idea is this: you have a pre-existing kind of socially constructed ethnicity. Race is arguably biological, but socially constructed ethnicity, and of course that determines your social environment. Let's face it. How much green space you have in your surrounding. What's your diet? Do you have all fast food chains all over? So are you eating unhealthy foods? Are you getting any physical activity? Are you exposed to a lot more violence? So it's not just about pollution. So and this can affect gene function at various stages. This can affect you. I mean, this shows you in utero. This can affect you in utero, in the developing embryonic stage. This can affect you as an infant, toddler, children. So adolescent, adult. You know, all stages. And so this affects gene function and arguably these DNA and DNA-associated proteins in the cell alter expression and are actually heritable. They're inheritable through meiosis and mitosis. So the modifications occur as a natural process of development and tissue differentiation and can be altered in response to environmental exposures or disease. So I'm leaving you with this. This is not the main focus of my talk, but be thinking about, don't leave out genetics. My point is this: when you're thinking about genes, don't leave this out in the consideration of social determinants of health. If methyl groups and epigenetics, and if some of these modifications, histone modifications, are it's too much to be thinking about at this stage, then I'll spare you the details of that. But if you're ready to listen, I'm going to give you a little bit more. I know you've been already listening to this for a while, but there can be modifications within the packed DNA of histones. So histones are actually very tightly packed DNA proteins, which if you modify in a certain way will not be expressed. And so there's just so many different ways that then DNA, social environment, can be affecting these histones, these methyl groups, and these chemical tags. And so I think this ends us to a point where we can wrap up. When you're thinking about social determinants, be thinking, of course, public health, about society, but be thinking about the medical factors as well. Be thinking about the biological, the markers as well, the biomarkers as well that are within the body, that are taking place, that are going on at the microscopic level. Be aware of all the changes within the body and how the interface takes place between the individual, society, and community. My colleague calls it the dynamic integration model. And of course, in another paper, I described this in conjunction with the dull green white-head rainbow model, which I provided from the 90s in this presentation. But everything is connected to everything, and until we bring it all back down to the core and kind of integrate all of the different environmental, social, and biological factors together to have a biopsychosocial robust model, we're still going to be grappling with a lot of diseases, whether they're infectious diseases or chronic diseases, which disproportionately affect historically marginalized populations. Thank you for listening.